Good morning. I'll be presenting today on gait and disorders of gait. My name is Aditya Kaushik. This will be the topic. These are the different contents under which I'll be talking. The different contents will be introduction, phases of gait, determinants, muscle contractions, patterns of gait, and the differential diagnosis, which will be in the end as a case discussion. Definition: as per the gait is defined as a interplay of events where there is constant change of gravity of the body with continuous losses and recoveries of balance with a rhythmic play of interplay where they narrowly avoid toppling, which actually means there will be a loss of gravity, loss of balance and the gaining of balance with the narrow margin where it narrowly avoids toppling. This is the actual definition of gait. By book the definitions are different, but to understand this definition better, these are phases: stance phase and the swing phase. Stance phase is 60% where the weight is supported on the ground. Swing phase is 40% where the limb is off the ground. These are different phases of gait, as I told. Stance phase is 60%, swing phase is 40%. The stance phase has heel strike, foot flat, stance, push off, which means the ground is on the foot is on the ground, and the swing phase where it starts to move off the ground. These are the two classifications. The Rancho Los Amigos is a newest classification. Traditional is a stance classification. Both essentially means the same, where there is no difference in the content. This is a pictorial representation where it shows the initial contact. 0 to 2% of the 60% cycle is heel strike, where the heel is on the ground. Loading response, where you actually plan for push off. That is known as a loading response. It's 0 to 10%. The foot is flat. The other name is ankle rocker, where you can tell the ankle is rocking to push the foot off the ground. The swing phase, the initial swing, which is 60 to 73%, where the lift off from the floor, where the toe leaves the ground, with the knee is inflection, which is a different topic of knee kinematics. Mid swing. Mid swing is a part at the mid of the cycle where the foot is in swing position, where the limb is in stance, but knee starts to flex and move off the ground. The tibia is in vertical position, as you can see. Terminal swing. It's in the end of the phase where the 87 to 100% ends with the foot striking the floor, as you can see in the second image. Double limb float, which means essentially means that when you start to run, the time the foot is on the ground decreases, which is increase in speed, decrease in double limb float time. That is the essence of this slide. Cadence. Cadence is a parameter of gait where it's number of steps per minute. As you can see, there are different parameters like stride length, step width. There are different parameters which is essential for calculating if there are any abnormalities in the gait. Temporal variables. The temporal variables is supported by time, where these are different parameters in time which you can calculate, like single cycle support distance, double support cycle, the stance and the swing of the cycle. These are different parameters when you come to abnormalities where you can contact all these. Neural control is, as you all know, we don't control our gait, we just keep on walking. We don't think we have to walk this amount of speed, this amount of distance, nothing like that. It's a neural control, it's autonomous control of gait, whereas spinal system plays a major role along with the brainstem, which indirectly makes the muscles respond to the commands which we give intentionally. Determinants of gait, which is known as pelvic rotation. When you walk, you can see the pelvis moves up both sidewards and forwards. This is the forward rotation, which is given as pelvic rotation, which tilts anteriorly and posteriorly when you walk. The pelvic tilt, as you can see, double support, both the pelvis height is the same. In mid stance, the pelvis height tilts, which denotes the pelvis is also involved in gait. Knee flexion, as I told before, knee flexion will be in two phases: the stance phase and the toe off phase. All the other phases, the knee will be straight. As you can see in the image, this is the center point is the knee. Ankle mechanism is also the same, where the ankle will be in the ground in two phases and off the ground in two phases. The center two phases, the ankle is on the ground. The first and the last, the ankle is off the ground. Foot mechanism. Foot mechanism is also the same. The center two phases, his foot will be full flat on the ground. The first and the last, the foot will be one and off, one will be on the ground partially. This is a different mechanisms to find out whether the gait is altered or not. Lateral displacement. This is the coronal movement, where the pelvis moves both sides, the lateral sides when you start walking. And this is a classical case of Trendelenburg gait. This is sagittal plane motion, where I told anterior and posterior pelvic tilt. All the other movements are accessory movements, but the main movement occurs in the pelvis. Kinematic is a sagittal plane, as I told before. The coronal plane motions, pelvic obliquity, which is above and below. foot progression angle is that where there's a angle of walking through the straight line, which is usually 20 degrees, not more than that. The different muscles involved in the different progress of gait. Mostly the pelvic muscles are involved when the foot is off the ground, and then followed by quadriceps, then goes down into the calf muscles, and then it comes from below upwards. That's the way we remember, up to downwards in stance phase, and goes from down to upwards in swing phase. This is the different muscle action, concentric and eccentric. As you know, concentric is there is no change in length, eccentric there is change in length. This is the different muscles involved. As I told before, from up to down it goes in stance and comes from down above in the swing phase. This is abnormal gait patterns. Antalgic gait is where the gait is painful. Patient will not keep the foot on the ground. There is no antalgic gait. It occurs in various conditions. This is a Trendelenburg gait, which is classical in abductor palsy, which will be seen in patients with the pelvis injury or long-term immobilization of the pelvis or any issues with the head of the femur. Basically, this is the way Trendelenburg gait comes into picture. There is a lurch to the affected side where the contralateral pelvis drops. Proximal muscle weakness gait is a neuromuscular disorder where you can see patients have the muscles of the proximal thigh and the around the abdomen region will be weak, so the patient will have to take his hand support to get up from the floor. Spastic gait occurs in cerebral palsy, where it is classically seen in kids with anoxial injury of the brain during labor or post-labor injury. Short limb gait, where there's a limb length discrepancy, where it is one limb is short, patient so has to compensate and walk with a sideward gait.